doing the screen, so if we're going this part of our screen and they complain, so I'll say, you heard me say this on immersion day, like when they reach across and say, yeah, that feels tight or that feels painful, I'll say, well, does that feel like that's binding up in the front or does it feel like it's stretching in the back? So if they say it's stretching in the back, then I'm thinking, what's this test? Pec major, okay? So I'm already thinking, okay, pec major. They get up here and they're like, it's stuck, can't get back there. That's serratus, okay? So they have painful arc at 90 here. That's middle trap, lower trap, upper trap. So now, and delts are gonna play into all that. So now you start putting together the pieces of the puzzle from the screen. So when I put them on the table, now we're gonna see what actually tests positive, fails. Okay, so first thing that I'm going to do with that patient is when I get them on the table is just take them through passive range of motion and see what passive range of motion looks like compared to active range of motion. So if this was the side that was tight painful, I get to hear tight and pain, but it's not a hard infield or a stretchy infield. I'm like, okay, that's going to be inhibition. Same thing here. Okay, that's going to be inhibition. If I take them and I can push them through and I say, so does that hurt and get worse the higher I go, or does that hurt and then you like pass through it? So if they say that they pass through it, then that tells me, okay, so they're probably gonna fail middle delt, middle trap, all that stuff there. If it's tight all the way up, but I can get them all the way up, then I've got more stuff that I'm gonna be looking at. So once again, it's not telling me only treat or test those things, but that's what I'm thinking I'm gonna be seeing test positive for inhibition. Okay, so just taking them through range of motion, same thing, take them through and just see what their range of motion looks like here. So if I've got a frozen shoulder patient and they only get here and they do this with their screen and they get here and they do this and they get here and I only get in the 90 and I can feel, yeah, that capsule is super tight, then I'm gonna go through and do my MOBs to get more range of motion because I can't assess half of my NFTs if they can't get past 90. So I got to get them past 90 to assess function, right? So I'm going to do my MOBs, maybe get them to like 100, 110. Now I got plenty of motion. So now I'm going to do everything. So middle trap, delts, delts, delts. That is going to open up more. Now I can get to lower trap, upper trap. That opens up more. Now I can at least get them in some position to check serratus, check that, then it falls back after I treat that. So I'm going to allow the majority of the range of motion gained be from facilitating the inhibited muscles. If I need to help it just to get some gross range of motion so I can get them in test positions, then I'm going to do MOBs. Okay. But once I've got them up here, I'm not going to do MOBs because then I got to go back and clean up whatever I turned off while I was doing the MOBs. Okay. Any questions on that? And also be aware of let them tell you what their facial expressions, all that kind of stuff when you're getting to sticky parts. Now for your post-op patients, if this is our post-op major rotator cuff repair who was in a sling for 6 weeks, hopefully the physician sent them in at like week 2 or 3 because we're going to be working on facilitation and all these ranges of motion while they're still in the sling. So they get out of the sling and they've already got 110 degrees of active flexion and abduction because we've already stimulated the stuff. They're doing isometrics at home to maintain facilitation. Now, I just had a guy come in 6 weeks in the sling, physician didn't send him in. He waited till 6 weeks post-op to make his visit. Well, we're 2 weeks out. So now the first time he gets in is 8 weeks post-op and he can't move anything. So for him, we had to do some MOBs to get things going. But then once I started turning things on, now when we get done with his first visit, he went from like 80 degrees of flexion to like 120 and pain here to no pain, just feeling like it's stretchy tight back here. So we made up a lot of ground, but it would have been a hell of a lot easier if he would have come in when he was still in the sling. So we can still assess neuromuscular function, do our NFTs when they're in the sling. We can still do our palpations when he's in the sling, unless they've got some kind of, and usually some of the bigger rotator cuff repairs will come with a range of motion restriction, like they don't want them to go past 30 degrees of external rotation, which is fine. So we're not going to do anything that requires an NFT of more than 30 degrees of external rotation. I'm still going to check him just as my own peace of mind. Okay, he gets all the way to 40 and he only needs to be at a 30. So we're ahead of the game. I don't need to push things. We're just cruising along. Okay. So now when we get to C-spine, going to be the same thing. So if they turn range of motion is more tight one way versus the other way, or they're more stuck here versus here. Now we're going to use the same thought process as we go through C-spine, because once again, our screen